Thank you, Naomi, for that sweet comment. May she indeed continue to rest in peace. She was a wonderful woman. She was a wonderful mother. So we are done with that. So now I want us to, let's see if there is any question. We move on to the anti-Parkinsonian drugs. I always tell I want to tell you as my student, safe. But appreciate for those of you who are still blessed with your parents, because I know, unfortunately, some of you might also have lost their parents. Now I've lost both of my parents. Let me tell you, my dear students, please respect those parents, honor those parents, love those parents. Do whatever you can for them. Because let me tell you, when they rest, the difference, life is never the same again. So I would ask you with humility that even if you have differences with your parents, for whatever reason, make up with them, love them, adore them. Do what you can, stand with them in good times, in bad times. Because one day you look back and you, of course, regret any day that you did not do the right thing. That is, I think, the message I can pass to you this morning as I continue to remember my dear mom. Respect, honor your parents. Indeed, that is the only commandment with a good promise, that honor with a blessing. Honor, respect your parents. They might not give you the best you want, but you see, what we want and what we need, those are two different things. And with those few comments, let us move on to the anti-Parkinsonian drugs. I don't think there's any question. And I'm hoping that you've read this, you've been reading the Narcotic Analgesics. I want us to do a cut. I was even thinking we can choose a date next week, not the day for the class, because we are already behind. But and you have an extra day, and we can do a fast cut. I had asked that last week. We need to do our fast cut because of marking. So let us get a date next week. If not next week, then we will not go beyond next week, but one. We do our fast cut because we are done with the narcotic analgesics, and it's actually the biggest topic within this unit. The others we have about another 4, but they are much smaller topics. So this morning again, I want to introduce the anti-Parkinsonian drugs, or drugs for Parkinsonism. And the first thing is, what is Parkinsonism? Have you done this in pharmacology? Have you done Parkinsonism, Parkinson's disease in pharmacology? Parkinson's disease, have you done anything about it in pharmacology? Class? Oh no, oof, not lucky then. Okay, fine, no problem. But we do know, I hope we have heard of Parkinson's disease, because even one of the best boxers, I think Muhammad Ali, died of Parkinson's disease. I think most probably during his fight, they hit him on the head. And indeed, he died. He had Parkinson's disease for quite a long time. And of course, finally, he died of the same. So when we define, we are saying Parkinson's disease is a degenerative disorder of the CNS dopaminergic neurons, which slows mainly motor and sometimes cognitive or thinking-related symptoms. So it is where the dopamine neurons die, they get worn out, they die. That's why we are calling it, it's a degenerative. They degenerate. The dopamine releasing neurons. And once they degenerate, that means the levels of dopamine go down. The levels of dopamine go down. Dopamine is known as the neurotransmitter which is responsible for motor relaxation. Acetylcholine is responsible for contraction. So once the dopamine levels go down, then it implies the acetylcholine levels, although they haven't gone up, There will not be a balance between acetylcholine and dopamine. And for proper motor activity, the acetylcholine and the dopamine must have a balance. So when the dopamine levels go down, it means that the acetylcholines will be higher than the dopamine levels, and therefore there will be an imbalance in the motor activity. You will have rigidity, you will have issues of movement and coordinated movement, and therefore, and that is indeed what we call Parkinson's disease. In the latter stages, of course, also you do have issues of acetylcholine, and you find that also you have dementia. In the latter stages, there is also a decrease in acetylcholine levels in the latter stages of Parkinson's disease, and you get dementia. So we are saying movement related, that is motor. You will get movement related, that is motor problems. You're saying, so the symptoms, related symptoms. So you get symptoms that are movement related, or that is motor activity, whereby you can have shaking. And I believe you have seen these people, even when you go to give them a cup, sometimes even our elderly parents or even our grandparents, you're trying to give them a cup. You're not talking about alcohol withdrawal symptoms, because if it's somebody who takes alcohol, could be alcohol withdrawal. But there are those who are not on alcohol or anything, but you find them shaking. Their hands are shaking. There is rigidity. There is slowness of movement and difficulty with walking. In fact, these people cannot walk. Sometimes they try to walk and they fall over. And also you find that they stoop because of the fact that they do not have enough dopamine levels. Art, of course, as I have said, in the latter stages, you can have cognitive problems, and this occur because also there is a decrease in acetylcholine. Parkinsonism is a clinical syndrome with 4 cardinal features. You can have bradykinesia. When, of course, you do pharmacology, you will be given all the terminologies, but I will not bother giving all of them. You will have them in pharmacology, but you can just understand them like you have bradykinesia, where you have slowness and deficiency of poverty of movement. So there is slowness of movement. You can't be able to move. For you to move, make a step, you can take almost 20 minutes. There is muscular rigidity, and that's why this person, the muscles are rigid, they will fall over. There is resting tremor. Even as they rest, they are shaking, which usually abates during voluntary movement. There is an impairment of postural balance, leading to disturbances of gait and to falling. Disturbances of gait. So these people are bending. Normally, they cannot stand straight. They are bending. So you can't see, it is indeed a terrible condition. It is a terrible condition, impairing your movement. You can't move. And of course, once you can't move, even when you sit, you still are you have tremors. And of course, we are saying you can't fall over, and hence a very serious condition. Therapeutic goal, and it is not possible to treat it, but you manage it. So the therapeutic goal is symptomatic relief through restoration of the balance between the neurotransmitter acetylcholine and dopamine in the basal ganglia. So all you want to do is return that balance. So how do you return that balance? You can return the balance by either reducing the acetylcholine or by increasing the dopamine. So you increase the dopamine, and you have the major approach is increasing the dopamine, and you can have different ways you can increase dopamine. You have different ways you can increase the dopamine. You can increase the dopamine by giving drugs that will increase its release, giving drugs that will stop its metabolism, giving drugs that are agonists that will act on the same receptor as dopamine and therefore also release the dopamine. So we look at the different ways in which you can increase the concentration of dopamine. And of course, there are also ways you can decrease the concentration of acetylcholine, but do know that, of course, if you increase the concentration of acetylcholine a lot, then again, you will have cognitive issues. Drugs do not treat the condition, but manage it. That is important to understand, that once, therefore, you get the Parkinson's disease, you will live with it. You can only manage that condition. Causes, it is caused due to an imbalance, as we have said, of dopamine and acetylcholine. They need to be balanced for you to have the smooth movement. For us to be able to move smoothly, these two need to be balanced. Dopamine causes muscle relaxation, while acetylcholine causes contraction. So their balance will balance when you require the muscle to contract and also the muscle to relax. Reduction of dopamine in the basal ganglia results in imbalance of those two and causes motor disorders, as we've already said. In some cases, at later stages of the disease, there is reduction of acetylcholine, which is also involved in learning and attention, leading to dementia. We've already mentioned all that. No, I try to do my notes well so that they are very simplified. So this is what we are looking at. So we are looking at when you are normal, there is this balance. When you don't have that disease, there is this balance of dopamine and also acetylcholine. But now, when you have a Parkinson's disease, you will have that there is deficiency in this portion here. There is deficiency. Sorry. You have deficiency in dopamine. Of course, that way, because we are looking like this is the pivot. So because it's lower, it will be, that's why it is on the upper side. We have deficiency of dopamine and you have an excess of acetylcholine. It's not that we have changed the amount of acetylcholine. The acetylcholine really has remained the same, but because of the fact that the dopamine is deficient, it will look like the acetylcholine is in excess. So therefore, for us to return the balance, we must increase the dopamine to help us restore the balance. The classification of the drugs, as I have said, we have several drugs which you can use for management of Parkinsonism, and we'll look at the main ones. The first kind of therapy you can have is cholinergic therapy. In cholinergic therapy, we have what we call the anticholinergic drugs. And of course, the anticholinergic drugs will reduce the acetylcholine effects in that they will reduce the amount of acetylcholine. They are antagonists to the muscarinic receptors, and therefore they will stop the acetylcholine from binding the muscarinic receptor and therefore reduce the acetylcholine effects, like the tremors, and these are in the early stages. Because when you have Parkinsonism, again, remember, we treat the symptoms. That's what we have said. We do not cure, we treat the symptoms. So this person has tremors. So what are we doing? We are giving anticholinergics to take care of the tremors. How do we take care of the tremors? Is to reduce the binding of acetylcholine to the receptors and therefore give antagonists of acetylcholine. We also have cholinesterase inhibitors like rivastigmine. Cholinesterase inhibitors, remember, acetylcholine is broken down by the acetylcholinesterase enzyme. So when you give the cholinesterase inhibitors, you are not decreasing the acetylcholine activity. You are actually increasing the acetylcholine activity. So the acetylcholine, the acetylcholinesterases are given at the latter stages of Parkinsonism to take care of dementia. When the acetylcholine levels go down, then at the latter stages, you can give rivastigmine, which is acetylcholinesterase inhibitor, to increase the levels of acetylcholine and therefore take care of dementia. Promotes acetylcholine effects, and it is mainly for management of dementia. Dopaminergic therapy. Now, so that was cholinergic therapy, where we can use both the antimuscarinic or anticholinergics and use acetylcholinesterase cholinesterase inhibitors, whereby they will inhibit the breakdown of acetylcholine. Then now you can go to the dopaminergic therapy. In dopaminergic therapy, this is where now you want to increase the levels of dopamine. And under dopaminergic therapy, we can look at different, again, modes of action. We do have a category of that drugs that we call dopamine releasing agents. So these ones, this compound amantadine. Amantadine will get into you give it, gets into the brain, and it gets into the stores. You remember those vesicles where the dopamine is stored, and it moves in, and therefore the dopamine gets out. So it helps in that it will help you release the dopamine from the storage site. We also have dopamine replacement. And in dopamine replacement, we are saying you give a compound, because you give a compound that can be easily broken down to give us dopamine, and we are going to see all this. Dopamine in itself, as you look at the structure, dopamine in itself, you cannot give it orally. You cannot give it orally. It is rapidly metabolized. And for sure, if you give it orally, also, when it gets into the body, it will bring a lot of toxicity, peripheral effects, because we have dopaminergic receptors in the periphery. So you give a compound. You give a compound that can be able to be taken orally, and that compound can move into the brain. And that compound is what we are calling levodopa. We will see the disadvantages as we move on. So you give a prodrug of dopamine, because dopamine cannot be taken orally. And then, so you can give levodopa, but also levodopa has a challenge of peripheral metabolism into dopamine. So peripherally, it will be metabolized into dopamine. Once it's metabolized into dopamine peripherally, the dopamine again will give you side effects. So what do? You give the levodopa plus an enzyme inhibitor. An enzyme inhibitor, that is an inhibitor that will inhibit the enzyme that metabolizes the levodopa. So you give dopamine, the carboxylase inhibitors, which is carbidopa, and the carbidopa will help the levodopa to exist in the periphery. The levodopa is not converted into dopamine in the periphery. The levodopa passes on and gets into the brain. And in the brain, you have your dopamine decarboxylase. It is acted on and gives you your dopamine, which you require. So it will inhibit peripheral metabolic degradation it should be of the levodopa. Dopamine receptor agonists, and these agonists are going pop straight to the dopamine receptor, and they have agonist activity. They can trigger the reactivity to bring about the same pharmacological effects as dopamine. And you have, again, two classes. You have the ergoline derivatives like bromocriptine, of course, a very complex structure, and you have the non-ergoline derivatives, and these are the drugs that are mainly used where you have ropinirole and pramipexole. So those will promote dopamine effects in the brain. They will act on the dopamine receptors, and therefore the effects will be the same as those of dopamine. Then we have another class which we call the metabolic protective agent. Metabolic protective agents, these are the drugs that will stop the metabolism. They will stop the metabolism, and you have aromatic L-amino acid carboxylase, that is the carbidopa, which will inhibit the metabolism of L-dopa. L-dopa is levo dihydroxyphenylalanine. You're going to see that more. So when you give the levodopa, this is the same as the levodopa. When you give it with the carboxylase inhibitor, the levodopa gets into the brain, and therefore it will give you the dopamine within the brain, and that is where you require the dopamine. Then you know that dopamine is a monoamine. It's a monoamine, and therefore you can give monoamine oxidase inhibitors, and specifically monoamine oxidase B. Monoamine oxidase B is divided. Monoamine oxidases are divided into two. We have the monoamine oxidase A and B. A found in the periphery, B mainly found in the brain. So you want to be specific. You want to be specific for the monoamine oxidase B in the brain, because if you give inhibitors of monoamine oxidase A, which again are found into the periphery, anything you take which requires to be metabolized by those drugs, by those enzymes, we can bring you what we call a hypertensive crisis. So you must be specific, so that you want to inhibit the monoamine oxidase that is found in the brain, so that the monoamine oxidase found in the periphery, which is A, continues working properly, so that if you need to metabolize noradrenaline in the periphery, you need to metabolize catecholamines, all actually aromatic amines within the periphery, including theramine and so on. They will still be metabolized in the periphery, and the inhibited enzyme will be in the brain, so that again the dopamine does not undergo that metabolism or that oxidation, and that will increase the levels of the dopamine. We also have the other enzyme, catechomethyltransferase, COMT inhibitors. We have entacapone, and again, this is another method. The dopamine is also metabolized through this enzyme catechol methyltransferase, whereby one of the hydroxyl group at position number 3 undergoes methylation. So again, if you inhibit that enzyme, again, you will have dopamine to have a longer duration of activity. So those are the various classes. I hope we have understood them. We have started again with the cholinergic therapy, dopaminergic therapy, and of course, the final one is dopaminergic therapy, but of course, where we are blocking the metabolism of dopamine so that we get high levels of dopamine. Let us now say something about the anticholinergic therapy. I mentioned a bit as we went along, and we are saying these antagonists, the cholinergic receptors are mainly two. You have the nicotinic and you have the muscarinic, and both of them have different effects. They have different pharmacological effects. So you do not want to go for the nicotinic receptor. You want to go for the muscarinic receptor, because the muscarinic receptor agonists are the ones which are responsible for the tremors and so on, or for the motor activity. So the antagonists of muscarinic acetyl receptors in the CNS tend to diminish the characteristic tremors of Parkinsonism. So we must go for specific drugs which are the muscarinic receptor, a muscarinic receptor antagonist. The structure-activity relationship, where are we starting? We are starting with acetylcholine. So our agonist or endogenous agonist is acetylcholine. So when we make these muscarinic antagonists, we must maintain some structural resemblance with acetylcholine and also bring in some structural differences so that this antagonist binds the receptor more firmly. It sticks there a little bit more, but it does not trigger any pharmacological activity. So there must be structural resemblance between the antagonists and acetylcholine, and there must also be differences that allows these antagonists to bind the receptor more firmly, to stay there a little bit, but not trigger any pharmacological activity. So you're saying structural modification of the natural muscarinic acetylcholine ligand acetylcholine leads to therapeutically useful anticholinergic. So this is the muscarinic acetylcholine receptor ligand. As leads to therapeutically useful anticholinergics. Replacement of the acetate moiety. So first, before even we go there, we want to look at our acetylcholine. This is our acetylcholine. Acetylcholine, this is what we're calling the acetoxy group. The whole of that up to there is acetoxy because of the oxygen. When we look at it there, it's just acetyl or acetate moiety. So when you put the oxygen, it becomes the acetoxyl group. You can see it also has the ethylene bridge or ethylene space or portion. Then if you look at acetylcholine, it also have the oxonium, or it has the onium rather. It has the onium ion. It is protonated. It has the onium ion or the quaternary. You can see it's a trimethoxyl, and of course this is also a carbon. So it's a quaternary ammonium ion. So it's a trimethoxyl ammonium ion or onium group. Again, you can see it's protonated at physiological pH. So this is what we are starting with, the acetylcholine. And what we are saying is that we must structurally modify this compound to give us a drug that now is not an agonist, but an antagonist. And first thing we are saying, replacement of the acetate moiety of acetylcholine with a Barker group, a Barker lipophilic structural feature. So that's one of the things that happens, that this acetyl moiety here can be replaced at acetyl. In fact, we can even look at it first. You can replace either the whole acetyl group, or you can just replace one of the hydrogens of the methyl group. So if you look at like this compound here, which is the first structural modification, what you can see we still have that, but this methyl group one of the hydrogens of this methyl group is replaced, because you see this carbon is that carbon there. So the 3 hydrogens are replaced with bigger groups or with different groups. So you have that, you can have remain that acetyl group, because that acetyl, this ester group, this ester group is important for recognition. So you can have it there, but it's not a must. As we are going to see, you can also change it. And the first change you can do is just modify or the hydrogen substituents that are on this carbon, on the carbon of the methyl group, and replace with different groups. And 2 of the groups can be very bulky, and then this other group might be small. So that was found. If you did this compound was still found to have activity. And of course, so this compound was still found to have activity. But because of the fact that it is an ester, esters again are readily hydrolyzed, and therefore it will have a short duration of action. So what was done is that initially they tried that move, but they realized, of course, these drugs will have a very short duration of action. So they moved now to this kind of change, whereby you can still see that ester there is replaced with a hydroxyl group, and the hydrogens are replaced with very, very bulky groups. So as I have said, the reason why we did not maintain the ester is because of the short duration of activity, because esters are readily hydrolyzed. But we are saying replacement of the acetate moiety of acetylcholine in the bulky lipophilic structure feature, that was one of the move. Conversion of the quaternary ammonium ion of acetylcholine to the tertiary amine function ensures movement of the drug to the CNS. Remember, you want to give these drugs orally. Acetylcholine does not have oral activity, being a quaternary ammonium ion. So it was given as a tertiary amine, and the tertiary amine, the drugs were given as tertiary amine. Although the tertiary amines are protonated at physiological pH, they still had good lipid solubility to be able to penetrate the BBB. So here we are saying 2 changes: change of the quaternary ammonium ion to a tertiary amine. Also, change of some of the groups attached to the ester, making them change of the hydrogen groups to very bulky groups for them to have better attachment to the receptor, or even the surrounding areas within the receptor, and not trigger any pharmacological activity. So we are saying here the acetyl methyl group is substituted with at least 1 phenyl ring for antimuscarinic activity. So you can see that is the acetyl methyl group. So let us now look at the SAR of the anticholinergics. Now, this is now what we have here. And we are saying this group here, so you can have that still as an ester group. This group here, it can be a hydrogen, it can be a hydroxyl group, it can be a hydroxymethyl group, or it can be a carboxyamide. So all those groups can be part of R1, can be any of those groups. R2 and R3 should be a carbocyclic or heterocyclic ring. It can be a phenyl ring. It can be a cyclohexyl ring. It can be a cyclopentyl ring for maximum antagonistic activity. So you're saying you can change these groups, hydroxyl group. Like if you look at this, although of course this does not, so the whole of this has been replaced with a hydroxyl group. But when you look at this, what we are saying is that when you look at this group here, these 2, it's like this group here and that group here. That's what we are saying. If you look at this group there, it's a phenyl ring, and that group there is a cyclohexane ring. So we are saying one of these 2 groups can be replaced with large phenyl ring. R1, if like R1 is a hydroxyl group, you definitely get rid of that, but we move on slowly. Big R2 and R3 groups bind to the hydrophobic region outside the acetylcholine receptor. That's what we're saying. Once you put these big groups, they are really not going for the acetylcholine receptor. They are going for the areas outside the acetylcholine receptor through hydrophobic bonds. And once they go for the area slightly outside the receptor, bind through hydrophobic bonds, the molecule becomes semi-reversible molecule. It binds permanently. It binds not permanent, but it binds more strongly to that receptor, not to the receptor itself, to the surrounding of the receptor. It's held more firmly, it dissociates more slowly, and therefore held firmly, dissociates more firmly, and is able to give you the antagonist activity. The hydroxyl group at R1 presumably increases binding strength by participating in a hydrogen bond interaction at the receptor. Remember, when you have this group here, this oxygen can interact with the receptor through a hydrogen bond. So if you replace it with a hydroxyl group, then you find that that hydroxyl group can also interact with the receptor through hydrogen bond. So we are saying you can change quite a number of the groups, but we are introducing two bulk groups. We are also introducing a smaller polar group. It can be a hydroxyl group, it can be a hydroxymethyl group, it can even be a carboxyamide, as we had earlier said. So here, first one, we were saying we have changes to R1, R2, R1, R2, or whichever R1 or so whichever ones we are looking at, they must be bulk groups. They must be carbocyclic groups, bulk groups, and we have said those groups are binding outside the main receptor and giving us a firm binding whereby this molecule is dissociating much more slowly. So that could happen. But we are saying that you still have the ester group. So now you want to see what can you do to the ester group, which we have already said. And we have said this ester group now. So we have already said what you can do to this group here. We have said R1, R3, R2. This can be a hydroxyl group. That can be a heterocyclic group, and that can also be an aromatic group. So this group also can be changed. This substituent may also be an ether, oxygen, or it may be absent completely. So you can completely remove that. You can completely remove this group. So this group can be completely removed, and you will be able to see compounds that whereby that group is not there. So let's see whether they have any of those compounds. Most of the compounds, or the ones that have all of them, there is that ether. Yeah, like in here, you can see this carbon. You can consider this carbon was one substituted to a hydrogen, and substituted to another hydrogen. So one of the hydrogen has become a hydroxyl group. The ether group was here. You remember, the ether group class was here. The ether group is attached to this carbon. I hope we are together. Let me go back. If you look at this compound here, we are saying this can be a heterocyclic ring. That can be a heterocyclic ring, or even a phenyl ring, and this can be a hydroxyl group. So do you see, those are the three substituents on that carbon. So if you look at this compound here, it means the ether group is completely removed. I hope you can see that. That if when you look at this compound, trihexylphenidyl, this ether group has been completely removed, and now this carbon comes and joins that there. So you have completely removed the ether group, but you retain a polar group by one of the hydrogens on the carbon being substituted with a hydroxyl group. I hope you can see the difference. This carbon is carbon, hydrogen, hydrogen, hydrogen. So consider that carbon is this one, whereby it's a carbon like that. It has a hydrogen. We'll just now draw just like that. That carbon is substituted like that. So now what we have then, of course, because it continues to the ester. So what we have done, put here, instead of that, put a hydroxyl group. Instead of this, put a benzene ring here, benzene ring, and then put the cyclohexane ring there. So you see now this carbon has a hydroxyl group, it has a benzene ring, it has a cyclohexane ring. Now, this carbon was attached to an ester. So this group was attached to an ester. So we have said you can completely remove it. So you completely remove that ester, and now you take this carbon, this group, and you bring it to, so this carbon, and you come and join it to your ethylene linkage. So that's what we have said. You can completely remove the ester, or you can replace the ester with an oxygen and you get an ether. So if you look at the other drug, sorry, we are here. If you look at like a benztropine, where you see, so that one is one of the substituents on the carbon, and that's one of the substituents. We said the third substituent can be a hydroxyl group, it can be a hydroxyl group, it can be a hydrogen, it can be a hydroxymethyl group, it can be even a carbamide. So here it is a hydrogen. And when it's a hydrogen, then now you replace your ester with an ether oxygen. So I hope that is clear. So that's because I want us to follow nicely, completely. So we are looking at the what we do with the ester group. So we are saying already we have, when we substitute a hydroxyl group, a cyclic group there, and a cyclic group there, whether aromatic or not, then if a hydroxyl group, we completely remove the ester. Or we can have this one as a hydrogen, and we don't completely remove the ester, we replace it with an oxygen, as I have shown there. So that's it. So ester group provides, so it can be an either oxygen or it may be absent completely. The ester group provides most potent anticholinergic activity, because that again, ester will also interact very well with the receptor through hydrogen bonds. So we find, so that is what you can do to ester. Now we are looking at substitution at the amine group. So we already have taken care of that. And we have said in most of these compounds, I explained very well that you will not have an ester linkage, because the ester linkage will undergo hydrolysis and the compounds will have a very short duration of activity. So now we move on and we are looking at our tertiary amine. In acetylcholine, this is a quaternary quaternary ammonium group. So we are saying the compounds possessing the quaternary ammonium group exhibit nicotinic antagonist activity at high doses. And remember, we do not want nicotinic activity. We also say they will have a problem with oral activity. So they will have those two problems, nicotinic activity and also issues of oral activity. Quaternary ammonium compounds possess most potent anticholinergic activity, but of course they are also highly anticholinergic. But of course, anticholinergic will include both. Anticholinergic will include both nicotinic and antimuscarinic. So methyl, ethyl, propyl, or isopropyl groups are tolerated. So usually we are therefore saying, because of the fact that if we have a tertiary a quaternary amine, you will have nicotinic activity. You prefer a tertiary amine. Once you put a tertiary amine, as we have said, quaternary ammonium compounds possess most potent anticholinergic activity. So you expect that your anticholinergic activity will go down a little bit, because you have changed from quaternary to tertiary. But you will have the advantage of oral activity. You will have also the advantage of lesser or minimal, if any, nicotinic antagonistic activity. So tertiary amines also possess antagonist activity, presumably by binding the receptor in the protonated form. Quaternary ammonium drugs are primarily used in the treatment of ulcers and so on. So all we are saying, therefore, you change the quaternary ammonium nitrogen to a tertiary nitrogen, and at the receptor site, it's going to be protonated. And as it is protonated, it will be able to bind the receptor, although not optimally. It will also have lesser nicotinic toxicity. And of course, that's what you'd prefer. Changes at R4 position. And you can look, so this is now the R4, so this is still our acetylcholine. Optimum chain length is 2 to 4 carbons. 2 carbon chain possess the most antagonistic activity. So this spacer should usually be 2 carbon atoms. It can be up to 4, but maximum activity is obtained when that group has 2 carbon atoms. And indeed, if we go back now with that understanding, we will be able to look at all our compounds and we'll appreciate that indeed, they obey that structure activity relationship of the antimuscarinic drugs. So you can look at this. So this is where you have that group there, and one of the hydrogens is a hydroxyl group, and therefore you get rid of the ester moiety, and the terminal nitrogen can be part of a pyridine ring. This is a pyridine ring or a heterocyclic ring, as we have always said, with retention of activity. Of course, these groups are much bigger, but remember we said when the nitrogen is part of a heterocyclic ring, there is a constraint, and therefore that molecule will still fit the receptor, and that is a drug called procyclidine. Then we have this other drug here, again very similar to the first one, and it is only that the nitrogen again is part of a piperidine ring. So we are saying that the nitrogen can be part of a heterocyclic ring with retention of activity. It's very similar, same structure as procyclidine, with the exception of the fact that in procyclidine we have the pyridine ring. In trihexyl phenidyl we have the piperidine ring. Then the benztropine mesylate. Again, these are, you remember we give all these drugs usually in form of salts to improve on their solubility. So when we look at this again, that is an ether. That is an ether, and the amino group again being part of a bicyclic ring with retention of activity. So if you look at that difference, again, remember this, what we are looking at, that from there, that is 1 carbon atom for the chain, that is another carbon atom, and then the nitrogen. So the nitrogen is still separated from the spacer with the spacer has 2 carbon atoms. If you look at this, that's a nitrogen, carbon 1, carbon 2, carbon 3. The spacer in this one has 3 carbon atoms, but do remember, since they are part again of a cyclic ring, there is constraint. And we did also mention the spacer can be between 2 to 4 carbon atoms with retention of activity. So that group there still agrees with our SAR for antimuscarinic activity. Again, these are the same kind of rings. It's a bicyclic ring. That's a phenyl ring. Again, part of a piperidine ring. The only thing we have changed is that ring, and that is what makes it different from trihexyl phenidyl. Again, here, diphenhydramine, this is a drug we have studied under the antihistamines. Under the antihistamine, it is an ether. So you can see again the same structure there, and we are separated with an ether, and here the nitrogen there, or the spacer, the nitrogen is separated from the ether with 2 carbon atoms. The spacer, as we said, is 2 carbon atoms, giving us a maximum activity. The terminal nitrogen is a tertiary amine, of course, protonated, of course, to give us maximum activity. Ethopropazine, again, very, very similar. This is our huge substituent, a bit different, though, but still giving us good activity. It's a bit different. The structure here is a bit different, but you can see this is 2 carbon atoms from that nitrogen. So we have to look at that. And this is our nitrogen there. It's still a tertiary amine, and you can still say that and that one, these 2 carbons are what the chain or our spacer, that is our spacer. Of course, this structure is a little bit different, but you can look at this as one here. We have that as one of a substituent, and that as the other of, so that you can consider this to be one of a heterocyclic substituent, and that is one of the heterocyclic substituent, but this time instead of a carbon they are attached to a nitrogen with retention of activity. So of course this has a slightly different, this is of course phenothiazine having a slightly different structure, but has still been found to bind the receptor because of the small, it has this structural similarity, and because of that structural similarity, even the fact that it has that substituent, and that substituent, it still is able to bind the receptor. But do remember, the phenothiazines are mainly used as antihistamines, and of course also mainly used. So you will not give that as an anticholinergic, no, but we are only saying it also does have activity. Of course, we have mentioned always that there are structures which will not completely fit the SAR, but have their structural resemblance, and therefore you will have some anticholinergic activity. We are saying tertiary amines are less potent receptor antagonists, but have greater selectivity for muscarinic receptors than nicotinic receptors. We also have said, also have agonistic affinity for other receptors, such as histamine receptors and also dopamine receptors. Tertiary amines have higher activity than quaternary ammonium ions because of they have higher lipid solubility and therefore exhibit more favorable bioavailability, both in the systemic and CNS bioavailability. Again, we have already said that, but we must be reminded that these anticholinergics will be protonated before they bind the receptor. They cannot bind the receptor before they are protonated, because the receptor is designed in a manner that it takes the anionic, the cationic, it requires that cationic charge on the drug. Anticholinergics too, this medicine will block the cholinergic nerve impulses that help control the muscles of the arms and so on. So we are saying they are anyway anticholinergics. They will block the muscarinic receptors and therefore reduce the tremors, reduce the rigidity in Parkinsonism. For normal motor and on muscle, the effects of acetylcholine and dopamine, we have already said, need to be balanced. In Parkinson's, dopamine levels decrease, but acetylcholine levels remain the same. Medicine decrease levels of acetylcholine to achieve a closer balance with dopamine. I think this is the most important point there, that anticholinergic medicine will decrease the levels of acetylcholine to achieve closer balance with the dopamine levels and therefore take care of the tremors. But the minute you remove, of course, the drugs, the tremors will come back. And that's why we are saying what we are doing is that we are treating the symptoms and not the disease. Because we are treating the symptoms of the disease. We are managing, not treating, managing the symptoms of the disease, but not being able to treat the disease. Benzhexol or the trihexylphenidal, very, very important drug. This is a drug that also is given for patients that are on the major tranquilizer like chlorpromazine. For when you give antipsychotics like chlorpromazine, you also give benzhexol, and you give it to control the tremors, because also when you give some of the side effects of the antipsychotics is tremors and so on. So again, you can give this. It's a very important drug, again, in management of Parkinsonism. It is an antimuscarinic drug that blocks acetylcholine effect on the muscarinic receptors. Again, that's a repeat. So you read, that's a repeat. The benzhexol lowers acetylcholine levels and maintains the balance that we already know. The trihexylphenidal is used for the symptomatic treatment of Parkinsonism disease in mono and combination therapy with L-DOPA. We will be looking at L-DOPA. So you give them in combination. You can give it alone, but again, you can give it in combination with L-DOPA. The L-DOPA will increase the levels of dopamine. The trihexylphenidal will lower the levels of acetylcholine, and you get a balance. Also used to control drooling of children, cerebral palsy. In older patients with Parkinsonism, it can increase chances of dementia. So if you must be careful to give anticholinergics to older patients, because we said if you lower the levels of acetylcholine, then you will precipitate dementia. And that is why we use anticholinesterase or anticholinesterases or acetylcholinesterase inhibitors in the older patients to increase the levels of acetylcholine. The next ones are cholinesterase inhibitors. The cholinesterase inhibitors are designed to increase levels of acetylcholine. So please note, they are the reverse. They do the reverse of the antimuscarinic drugs, but they are doing the reverse not by binding the same receptors. These ones bind the metabolizing enzyme, and therefore the cholinesterase enzyme, which is a metabolizing enzyme for acetylcholine, is inhibited. And once inhibited, you have very high levels of acetylcholine, and therefore you can only use this in the latter stages to improve dementia. And the example of a drug that we have is the rivastigmine. And what you will find is that when you have acetylcholine binding, when acetylcholine is being metabolized by the cholinesterase enzyme, you find that acetylcholine has an ester. So it esterifies the cholinesterase enzyme, and the ester linkage easily breaks. When you have like rivastigmine or the cholinesterase inhibitors, they have what you have called carbamate. Carbamate is where you have an OC double bond on NH2. Carbamates are stabilized by resonance, as we have done earlier. Carbamates are a little bit more stable than esters. So when you have this drug, rivastigmine, which is a carbamate, it will carbamylate the cholinesterase enzyme. The hydrolysis of that complex of the drug and the enzyme will take a little bit longer. And if that hydrolysis takes a little bit longer, it means that the enzyme that is responsible for metabolizing acetylcholine will be held a little bit longer, and therefore the rate of metabolism of acetylcholine will go down. So it is the structure difference. Rivastigmine is a carbamate. Acetylcholine, we are considering them both to be substrate. Acetylcholine is an ester. Acetylcholine will esterify, whereas the rivastigmine will carbamylate. And that difference, the carbamate is more stable than the ester. And that is a difference which allows these drugs to allow acetylcholine to accumulate. So it is an acetylcholinesterase. Also, you have the butyl cholinesterases, which cause pseudocholinesterases. These are mainly found in the periphery. Inhibitor used to treat dementia that sometimes occurs at latter stages of Parkinson's disease. It increases levels of acetylcholine by blocking its degradation from the enzyme the acetyl or butyryl cholinesterase. This improves, again, the cognitive functions like memory and awareness, as we have said, not in the early. If you give it in the early stages, it will worsen the Parkinsonism because it will increase again the levels of acetylcholine. The acetylcholine already is imbalanced with the dopamine, so it will bring a lot of problems. Side effects are mostly nausea and vomiting, and at low doses it is, but at low doses is generally safe. It can sometimes dangerously slow the heartbeat, in which case atropine can be given. Of course, you know acetylcholine. So acetylcholine can slow the heart rate, and therefore you give its blocker, which is atropine. What is its mode of action? Is just what I've explained. That if you look at this is our drug here. This is our rivastigmine. That is our rivastigmine. So you can see this is what we are calling the carbamate. O C double bond O N CH3 CH2. So this is the carbamate here. Here is our carbamate. And in fact, the actual carbamate is from that, the C double bond NH. And remember, whenever you have this lone pair of electrons, remember we had done this a long time ago. This has a lone pair of electrons, two of them. So they can come in here. When they come in here, you have a double bond there, and this goes out. That goes out. So that this would have a negative charge. If this has a negative charge and this has a double bond, that is a stabilized molecule. Remember, it will be at a lower energy level. It's not very reactive, but it still can be hydrolyzed. So all we are saying is that when you give this rivastigmine, And you can see that, when you give this the rivastigmine here, this, remember, all these drugs, all these enzymes, like the cholinesterase enzyme, it usually has a serine moiety. Most of these enzymes bind through their serine moiety, and their serine, and we have mentioned that in most of the enzyme, and their serine moiety has a hydroxyl group. So this is the serine moiety, because this is, we are considering this is a cholinesterase enzyme here. So the whole of this. So it is having this hydroxyl group as a serine moiety. So this hydroxyl group is a nucleophile. It has lone pairs of electron. This carbon here is having electrons pulled by the oxygen, and electrons pulled by the oxygen. So this carbon here has a small positive. It is electrophilic. So these electrons here on the hydroxyl group of the serine moiety will attack. So this is nucleophilic. It will attack the electrophilic carbamate of course. This is our drug. That is our rivastigmine. Once it attacks there, then it will come and join here, and this will come there, and there will be a cleavage. So the cleavage will be there. So there will be a cleavage there, and this molecule will go out as a hydroxyl group. And you can see now this carbamate here. This is now the carbamate joined onto the enzyme, and that is what we have here now. So you have this group has gone out. You can see that group has gone out, and if you look at the enzyme, I say this is the whole of this is the enzyme. So now this is the hydroxyl group of serine. So you can see hydroxyl group of serine has joined the portion of the drug. You can see this is a portion of the drug, this here, and the C double bond O. So that drug, the C double bond O, and joined there. So indeed now the enzyme, the cholinesterase enzyme, has been carbamylated. A carbamate has been added. It has been carbamylated. This complex now is the one which hydrolyzes slowly. If it was an ester, it will hydrolyze very easily. And we have said it will hydrolyze very slowly because the carbamate is stabilized by resonance. So it's more stable than the ester, and therefore it will be hydrolyzed slowly. And since it will be hydrolyzed slowly, there will be irreversible blockade of the cholinesterase enzyme. And once there is that reversible blockade of cholinesterase enzyme, it means the rate of hydrolysis of acetylcholine will be much slower, so the levels of acetylcholine will increase. I hope that is clear. So if you look at this, it's the same, a different way, the same. This is our serine. So that's our hydroxyl group attacks there, and that leaves. So you can see this is our enzyme here, which has been carbamylated. That enzyme has carbamylated. The rate of activity is the primary amine, higher activity than secondary amine, higher activity than tertiary amine. Of course, this will be contributed to steric hydrons, because you can see this group here. If it is very bulky, if that group is very bulky, then it will interfere with the accessibility of the enzyme on the carbamoyl group, on the carbon of the carbamoyl group. So therefore, it requires to be small enough to allow the hydroxyl group of the enzyme to be able to attack the delta positive carbon of the drug. Again, of course, when you have very large, remember, if you have large alkyl groups are electron donors. So the larger they are, the lesser they will make that an electrophile. So because of those two reasons, that if you have large groups, they will lessen the electrophilic nature of that carbon. And of course, also, if you have large groups, they will also introduce steric hydrons and hence decrease the rate of carbamylation. And once you decrease the rate of carbamylation, then of course that resultant drug will have a much slower rate of activity. So that finishes the cholinergic drugs. both the muscarinic antagonists and the acetylcholinesterase inhibitors. Is there any question? Then from there, we move to the dopaminergic therapy of Parkinsonism. Remember, we are saying we either decrease the acetylcholine depending on the stage, or increase it, of course, depending on the stage of the Parkinson's disease, or we increase dopamine. So now we are moving on to increase dopamine. And one of the ways we can increase dopamine is just giving drugs that will release dopamine. That means the drug you give will be able to bind the receptors. It will be able to use the same transport mechanism. Remember, most of these neurotransmitters use transport mechanisms to get into the vesicles to be stored. So what happens is some of these drugs, when you give such a drug which is releasing, it uses that transport mechanism, it gets into the storage vesicle and it displaces the neurotransmitter, and the neurotransmitter definitely is free to bring about activity. Some of them also will stop the reuptake of that neurotransmitter, and therefore the concentration of the neurotransmitter is within the surrounding the receptor is much higher, giving you much higher dopamine activity. So one of the drugs is known as amantadine, and it displaces presynaptically stored dopamine into the synaptic cleft, as we have said, just to get it released. It uses the same transport mechanism, gets in, pop, it gets out. This drug, if you look at it and you can look at the structure, it has an amino group. So you'd expect, because this is a free amino group, you'd expect it to be protonated at physiological pH very gently, and therefore stop this drug from being absorbed. But what happens because of this, we call it a cage-like structure. This amino group is hidden. So that amino group is hidden by the cage-like structure. Neither is it metabolized, because amino groups undergo very rapid oxidative deamination, and neither is it protonated, and therefore amantadine has very good activity. So we are saying it has a high pKa, so it's highly basic, and therefore it's extensively ionized. It will be extensively ionized at physiological pH. So that's what you'd expect, that because it is an amino group, highly basic, to be extensively, this is the expectation, to be extensively ionized at physiological pH. But we are saying because of the cage-like hydrocarbon, which we call, this cage-like is what we call adamantane structure, provides lipophilicity and prevents oxidative metabolism, so that significant quantities the drug can penetrate the CNS. So because of this cage-like structure, it's able to hide the amino group. The amino group is not metabolized. This compound also has high lipid solubility. It's able to get to the brain and give us activity. What are the disadvantages of this drug? You must have some stored dopamine. If you don't have any stored dopamine in the vesicles, then it will not have activity. So it's associated with the use of amantadine, include low efficacy and a dependence on the presence of presynaptic dopamine stores. So if you exhaust your dopamine stores, even if you give that drug, it will not have activity. So it has low efficacy, and the fact that you must have the dopamine stores. So that is adamantine. Again, we will come across this drug again, because it's also used in other, it is also used as an antiviral agent. So we'll come across it again when we look at the antivirals. The mode of action, we've already said, it promotes dopamine release from dopaminergic nerve terminals in the nigrostriatum and delays its reuptake in the CNS. Although mostly protonated in the blood, the unique cage structure provides a very high lipophilicity for good penetration into the brain. Cage-like structure also prevents metabolism, such that it is excreted from the kidney and change. We have already mentioned its disadvantage. So the cage-like is what gives it a lot of protection. It gives it a lot of lipid solubility. It gives that drug protection also from metabolism. How is it synthesized? So you start with your adamantane there, and you can do bromination, or you can react it with nitric acid to get a bromo derivative or a nitro derivative, and then you can react either with sulfuric acid, or you can react with you can react with a nitrile derivative, and then with sodium hydroxide to give us adamantane. Reacting adamantane with bromine or nitric acid to give bromine or nitro ester at position 1. Reaction of either compound with the acetonitrile, that's a nitro derivative, is the acetonitrile, avoids the acetamide, which is hydrolyzed to give 1 adamantane, adamantyl amine or adamantane. So it's a very simple procedure of synthesis. So that's why I thought it was good to put it there. It's very, very simple. You can either react with bromine or with nitric acid. The next one is dopamine. As I say, these ones are usually small groups and not very detailed. The next one is dopamine replacement. So when we do replacement, we are saying it's like we are giving dopamine. You want to give this patient dopamine, but dopamine from its structure. Dopamine from its structure, it has a catechoamine, so it has 2 hydroxyl group, it has an amino group. It cannot pass. It is too polar. Number 2, it's highly metabolized within the periphery, so it can never get to the brain. So that's why we are giving L-DOPA. So exogenous replacement of dopamine is unsuccessful because dopamine cannot access the CNS from the periphery because of one, it's structural hydrophilicity. It has a very high water solubility. The ionization, it is a strong base, and therefore to be ionized at physiological pH, and also because of high metabolism. So it is structurally it's highly polar. That's what we call structural hydrophilicity. Highly polar, highly ionized, and rapidly metabolized. So those 3 facts stop dopamine from accessing the CNS, and therefore you cannot give it in the management of Parkinsonism. It will also, the other problem is when you give it as dopamine, as we have said, if it gets into the periphery, it will also give you a lot of side effects. So, and even when you give L-DOPA in the periphery, it will be changed to dopamine, will give you a lot of side effects. So exogenous administration of dopamine that produces a variety of adverse effects as a result of dopamine interacting with various monoamine receptors in both the CNS and in the peripheral nervous system. So again, there is danger of you giving dopamine or even giving a compound that can release dopamine in the periphery. Remember, we have those receptors in the periphery, and therefore, once the dopamine binds the peripheral receptors, it will definitely give us a lot of toxicity. Effective delivery of dopamine to the CNS is achieved by use of the exogenous but synthetic precursor, which we call the L-dihydroxyphenylalanine, or L-DOPA, which is also levodopa, which accesses the CNS sites via an amino acid transporter. So it uses an amino acid transporter, is readily carboxylated in the dopaminergic neurons, dopamine by DOPA decarboxylase. But again, remember, yes, L-DOPA will get into the brain, dopamine will not. But L-DOPA will also be metabolized by DOPA decarboxylase in the periphery to give you dopamine. So it will still give you a lot of toxicity. And of course, also, most of it will be decarboxylated, so very little of it will reach the CNS as L-DOPA. Significant concentrations of dopamine are formed in the peripheral nervous system related to peripheral DOPA decarboxylase activity, giving rise to peripheral dopamine stimulation, primarily CVA. So we still have a problem. If you give levodopa, you still have a problem. You need to take care of the peripheral toxicity of the dopamine that is formed in the periphery by decarboxylation of L-DOPA. And that is where now we combine L-DOPA with carbidopa. L-DOPA with carbidopa. So we are looking at addition our dopa decarboxylase inhibitor, carbidopa, improves the CNS bioavailability of L-dopa. So here is our L-dopa. You can see the difference between L-dopa and dopamine is that L-dopa is L-olive dihydroxy there, phenylalanine. So of course it's an amino group. So it has an NH2 and a COH there. So when it undergoes decarboxylation, it loses that COH, and that's to give us our dopamine. But you can still see that dopamine protonated at physiological pH, that dopamine having two hydroxyl groups being a catecholamine, or having a catechol group, and therefore high water solubility, not able to penetrate the membranes. So what we are saying, the enzyme here responsible for decarboxylating or L-dopa, changing L-dopa to dopamine, is what we call aromatic amino acid decarboxylase, and that enzyme can be blocked by carbidopa in the peripheral, can be blocked in the peripheral nervous system, can be blocked by carbidopa. Again, look at the structural resemblance, because you must have, you see, this carbidopa is being taken up by the L-dopa. Both of them, it's taken up, the dopa, the L-dopa decarboxylase uses the pyridoxine cofactor. So it binds the same way, the carbidopa binds the same way the L-dopa binds the dopa decarboxylase, but it is an inhibitor. Once it's taken up by the dopa decarboxylase, it inhibits it. It does not trigger, it is not metabolized. So therefore, it blocks that enzyme from metabolizing L-dopa, and therefore L-dopa is not metabolized to dopamine within the periphery. L-dopa is available in higher concentrations to penetrate the membrane and to get into the brain, and the carbidopa does not pass through the membranes, so it cannot inhibit the metabolism of L-dopa within the brain, does not pass through the BBB left in the periphery. The L-dopa passes in the brain. You also have the dopa decarboxylase. It is decarboxylated. It gives the dopamine, and wow, the dopamine concentrations will go up, and that is exactly what you want. So levodopa is absorbed from the small bowel, peak plasma levels, and may be delayed in the presence of food. The rate of absorption is dependent upon the rate of gastric emptying, pH of the gastric, juice, the length of time the drug is exposed to degradative enzymes of gastric mucosa, because it liberates the dopamine. pH of the gastric juice. Remember, this is a basic drug. Basic drugs are better absorbed in basic environment because they'll be more anionized in basic environment. So if by any chance that pH is slightly acidic, then that will reduce its absorption. So that is just physical chemical factors. It is extensively metabolized in the periphery and in the liver. Very low amounts get, as we have said, penetrate the CNS and change. It is excreted primarily in the urine. The major urine metabolites of levodopa appear to be the hydrophenyl acetic acid, that is DOPAC, and HVA. We are going to look at its metabolism. That we've already said. So we look at its metabolism last. So carbidopa, we have also said, it is a pyridoxal dopa decarboxylase cofactor trapping agent. In other words, it will the dopa decarboxylase requires the pyridoxal cofactor. So the enzyme, you will find it as a complex of pyridoxine dopa decarboxylase enzyme. And what we are saying is that the carbidopa will bind that enzyme and trap it. Once it traps it, it's not available, as we have said. It is a dopamine decarboxylase inhibitor. It will increase, as we have said, its purpose is to increase efficacy of L-dopa by preventing its peripheral metabolic degradation. Inhibition of L-dopa decarboxylase allows more L-dopa to penetrate the brain. Decarboxylase exists both inside and outside the brain, but carbidopa only blocks metabolism outside the brain. It cannot penetrate the brain. So we have the decarboxylase both in the brain and outside the brain. Carbidopa cannot penetrate. So that means the carbidopa will be locked in the periphery, and it will allow for the L-DOPA penetrate, and in the brain to be metabolized by the DOPA decarboxylase enzyme. This is what we are saying. That is our carbidopa. And the this is the DOPA decarboxylase. This is the pyridoxine. So remember, we have said it uses pyridoxine as a cofactor. So that is the enzyme bound to pyridoxine as a cofactor. Now, when this binds, this comes and binds the pyridoxine at this level, I think it is binding at this position here. It's binding on this group here. So it has this NH3, so it's a hydrazine. So it comes and binds at this group, and now it traps the enzyme. So it's trapping the enzyme plus its cofactor, and it traps the enzyme. Once it traps the enzyme, then the enzyme is not available to hydrolyze L-DOPA, and therefore L-DOPA is it's not available to bring about the carboxylation of L-DOPA, and therefore L-DOPA is available to penetrate the BBB and get into the brain, and therefore bring about its activity. So we can just briefly look. I hope we have a few minutes. So this is just the metabolism of L-DOPA, and this is the structure of L-DOPA. Again, remember, L-DOPA is just dopamine, the carboxylic group. So that's all. So this is the carboxylic group required to remove, and we are looking at which are the ways in which L-DOPA can be metabolized. It can be metabolized in reaction catalyzed by the carboxylase enzyme, and then of course there is a COMT, and there is also the monoamine oxidases. So you can find that L-DOPA undergoing decarboxylation. So it undergoes decarboxylation. You can even look at it here, L-DOPA. There, this is decarboxylation, aromatic amino acid carboxylase, and then to give us dopamine, and then it can also undergo methylation. This is O-methyl transferase to give us 3-O-methyl DOPA. This is a 3-O-methyl DOPA that is structured there. And this is happening in the periphery. So if that metabolism happens in the periphery, you've lost the L-DOPA. And then you have it crossing into the brain. And once again, it crosses into the brain. The same metabolism can happen into the brain, COMT, also the carboxylase to dopamine, to the 3-O-methyl DOPA. You find this 3-O-methyl DOPA also has some side effects. So it can go into the carboxylase to dopamine. And now when you have the dopamine can undergo oxidation. And once it goes oxidation, it will give us a 3,4-dihydroxyphenyl acetic acid. So it undergoes dopamine by monoamine oxidase P, which is found in the brain, as we said. It undergoes oxidative deamination. It goes oxidative deamination to give us DOPAC, or 3,4-dihydroxyphenyl acetic acid, and then DOPAC again can undergo it can undergo oxidative O-methylation. So one of these methyl groups attains, one of these hydroxyl group attains a methyl group to give us a 3-methoxy-4-hydroxyphenyl acetic acid, and that's what we're calling homovanillic acid. So the same thing can happen on this side. The dopamine, it's only a change. The dopamine, you can have it first metabolized by monoamine oxidases and then COMT, or you can have the COMT start and then monoamine oxidase. So what we are therefore saying is that we want to prevent the metabolism, peripheral metabolism, and that is why we are giving the carbidopa, and the carbidopa is left within the periphery. We have more of the L-DOPA crossing the BBB, getting into the brain. We do not, of course, want these other metabolisms. We don't want the COMT to be very active. Don't want the MA or B to be very active. And therefore, some of the other drugs that we are going to discuss are COMT inhibitors, monoamine B inhibitors, which again, you cannot give in combination. You can give them in combination so that you retain the high levels of the dopamine. And once you have the high levels of dopamine, then you will have the balance between the acetylcholine and the dopamine, and you will be able to relieve. Remember, it is relieving the symptoms. You will be able to give that patient quality life. You will be able to give them quality life, but you cannot be able, as we have said, to treat the disease. I think with that, you can sign in. I'm sorry, 13 minutes, but we also started late. I had signed in early, but you guys signed in late. So can you show that you are there? Can you sign in quickly? Can see we are 34. And I hope you are okay. And if there are any questions, kindly ask the questions. I know now next time we should be able, you're not far from finishing.